This is an orientation to the clinical protocols that became effective on January 1, 2024. This new version of the protocols are digital only. They will be available on the computers or tablets in each truck, and the EMS website, then navigate to the Educational Courses tab. It's also available on the Target Solutions bulletin board, and a LAD Tech in the storage area. They are in PDF format, so you are welcome to download them to your device. I will highlight some of the changes that are taking place and some of the concepts of the new protocols. You can see as you scroll down through this PDF file, there is an introduction. I would urge everyone to read this introduction. It will explain the concept of the Universal Patient Care Protocol. All patient care begins with this protocol. As you develop your differential diagnosis and you want to treat a specific condition, you would go to that specific protocol. Protocols are not designed to cover every situation you might encounter. If there is a situation that you would like to give a medication or perform a procedure where a protocol doesn't exist, you would need to contact medical control for orders. The new protocols have similar sections as we have had for a long time, however, they have been totally reworked to allow you to find what you are looking for, faster. As we move down through this, we see a major change. All provider levels will be on the same protocol. These protocols will be used for the volunteer fire departments who use Dr. Fleming as their medical director. This means we will all be using the same protocols. You will see these boxes in the protocols. The following letters and colors are used to differentiate between the provider levels. R will be for emergency medical responder, E will be for emergency medical technician, A for advanced EMT, and P for paramedic. The box to the right of the letters will indicate what that level of provider should do in that particular protocol. There is a statement of responsibility that indicates that the highest level of certification or licensure holds joint responsibility with the lower level provider. Near the bottom of this page are the various resources that were used in the development of these protocols. As you move down to the table of contents, each protocol title is hyperlinked to the protocol. So when you click or touch the link, you will be taken directly to the page you want to view. You'll notice there are no numerical page numbers. Each section is color-coded with a numbering system that is specific to that section. This will make it easier to make changes without having to renumber pages. As mentioned before, each line is hyperlinked to the page. As an example, if you wanted to look at the criteria for death, withholding resuscitation policy, simply click or touch on the line and you are taken directly to that policy. The various sections include policies. These are clinical policies, not human resource policies. The procedures have been divided into the different types of procedures. For example, airway procedures, assessment and screening procedures, cardiac procedures, parenteral access procedures, respiratory procedures, universal procedures, and trauma and wound care procedures. Following that, you'll find the general protocols. General protocols are protocols that are general in nature. For example, all protocols start with the Universal Patient Care Protocol. You'll notice the behavioral protocol has been separated into 3 different protocols named Behavioral Health Crisis. This is to allow for different forms of treatment as a behavioral health crisis escalates. Next, you will find the airway respiratory protocols for adult and pediatric patients. Following, you will find the adult cardiac protocols, the adult medical protocols, pediatric cardiac protocols, pediatric medical protocols, obstetrical and newborn protocols, toxin environmental protocols, and special operations protocols. On the next page, you'll find trauma and burn protocols for adult and pediatrics. Next, you will find triage and destination plans. This is a new category. You'll see more on this a little later. The appendix has been revised with the newer rule of 10's fluid formula for burns, as well as the familiar Parkland burn formula. The critical care drug list and EMS drug list have both been updated with new content. As mentioned, the EMS drug list has been updated from the previous version. 2 new medications have been added. The first is ketamine. Ketamine will be used for severe pain and also for the severely agitated patient. The EMS drug list shows the generic name and the brand name. Indications are listed as they relate to our protocols. Any contraindications are listed. Adult and pediatric dosages are also listed if they apply. Also, you will see that norepinephrine or Levophed has been added. Norepinephrine is included in the hypotension shock protocol as an alternative to dopamine. You'll see the adult dosage listed, and for norepinephrine there is no pediatric dosage listed for our use. Going back to the table of contents, as mentioned earlier, there are 3 separate behavioral health crisis protocols. The 3 are defined as anxiety but not disruptive, anxiety and disruptive, and excited or agitated delirium. We'll look at each one of these protocols. In the anxiety but not disruptive protocol, always call for help or additional resources if needed and withdraw from the scene until it's safe. This protocol begins with what the emergency medical responder can do. For example, establishing rapport with the patient, creating a quiet and safe environment for the patient, identifying any major medical problems that may be causing the anxiety, and finally assessing for suicidal or homicidal ideations. Finally, for the emergency medical responder, if pulse oximetry is available, they can apply the pulse oximeter probe. The protocol then shows the advanced EMT can begin venous access if appropriate. Then the paramedic can apply the cardiac monitor. If the anxiety is still causing physical symptoms, the paramedic has the option of administering midazolam. Always make sure you notify the destination hospital, especially with behavioral patients, so they can be ready or what you are bringing them. The second behavioral protocol is defined as anxiety but disruptive. In this protocol you'll see many of the things included in the first protocol. The biggest difference is the dose of midazolam is increased. Notice there are different dosages for patient over 50 kilograms and patients under 50 kilograms. The third behavioral health crisis protocol is for excited or agitated delirium. This is reserved for when the patient is in immediate danger to themselves or others. Excited or agitated delirium is not an official diagnosis. It's more of a syndrome. Scene safety is paramount with this patient. We have ketamine available for this patient. One important note is that we do not take suggestions from law enforcement about sedating patients. It's important that you understand ketamine. Ketamine can be a safe drug when used correctly, and it can be a very dangerous drug if used incorrectly. Always have your airway equipment including BVM, intubation equipment, suction, pulse oximetry, capnography. Also have your ECG monitor ready. You'll notice the EMTs have additional medications that they will be allowed to give. In the airway respiratory protocols you see the respiratory distress, COPD, asthma protocol AR7. For the EMT we have added acquisition and transmission of a 12-lead ECG and waveform capnography. Below that, if there is wheezing or stridor, the EMT can use CPAP and a nebulizer treatment with albuterol sulfate and ipratropium bromide. Also with pediatric asthma and respiratory distress, the EMT scope of practice mirrors that of the adult protocol. In the allergic reaction protocol there is expanded EMT scope. The protocol was simplified with only 2 categories, mild and moderate to severe. You'll see EMTs can now draw up epinephrine and give an intramuscular injection, and then if there is wheezing they can give the nebulizer treatment with albuterol sulfate and ipratropium bromide. These modifications are also reflected in the pediatric protocols as well. The appendix has been updated also. There are new burn resources from the American Burn Association. The APGAR scoring is still there. The critical care and EMS drug lists have been updated. And you still have the difficult airway evaluation, dopamine dosing chart, and an updated LVAD resource guide. The last thing I want to show you is the triage and destination plans. This is a new category. This section includes cardiac arrest, pediatric, STEMI, and stroke. The trauma triage destination determination satisfies the state requirement. None of these plans take the place of patient choice. These are ideal destination for these particular patients. These plans also do not take priority if you have a patient who is unstable and you need to stop at the closest facility for stabilization. First is the cardiac arrest destination plan. It simply shows the difference between traumatic and medical arrest. Next is the pediatric plan. This plan shows how patients should be prioritized either to Norton Children's or University of Louisville. Next is STEMI, in which identifies which hospitals have cath labs. Next is stroke, and following that is adult trauma triage destination plan from the American College of Surgeons. Red criteria is high risk for serious injury. Yellow criteria is moderate risk for serious injury. That concludes the brief overview of the protocols. If you have any questions or concerns, please feel free to contact Mike Hunter at any time.